Good afternoon, and welcome to this brief review of the first week of class notes for neuropharmacology. We're just going to dive right in here. One of the first things we mentioned in class was the law of effect, which was drafted by Timothy Leary, who investigated different treatment modalities, including medication, weighting, talk therapy, and placebo therapy in depressed patients. And what he found was that all of these had the same rate of success. He also described a couple of components that contribute to the efficacy or the experience that a patient has with a medication. The first thing that he described was SET, so S-E-T, SET, which refers to the conditions of the patient, meaning the physical conditions, the set of conditions that define this patient. If you think in mathematical terms, set notation, what is the patient? For example, does he have a genetic predisposition to certain conditions? Is he overweight, underweight? How fast is his metabolism? These types of things. But that also encompasses how the medication is taken. It's time of day, with food, without food, while stressed out, after exercising. All of these things are described by SET. Setting is more along the lines of the expectation of the patient. And when we say setting, you can think more of the psychological setting, so the setting within the patient's mind. This refers to the mood the patient's in. Is he angry? Is he happy? Does he like the physician? Does he not like the physician? Does he think this medication will work or not think this medication will work? So between set and setting, set being the biological and setting being the psychological, we have a pretty good idea of what the patient is bringing to the drug, to the treatment modality. And then finally, dose is self-explanatory. That's the amount of drug given. And so the law of effect is essentially the idea that all of these three things interact to determine the patient's experience with a pharmacological intervention. We then went over the I-LADMI mnemonic, and we'll go through that one at a time. The I stands for intake, and it just so happens that pretty much every mode of intake starts with an I. So whether you're ingesting the pill, infusing the pill, injecting the pill, inhaling the pill, implanting some sort of timed release intervention, or inserting something into the body, such as a suppository, this refers to just getting the drug into physically your body. Then there's liberation, because you don't know what state the drug is in necessarily at the beginning. It might be good to go, but it might also need to dissolve. It might need to ionize. It might need to lose some hydrogens and become an ionic form. Whatever has to be done to get it, in the solution of your body is liberation, is getting the drug out of the pill. Then you have absorption. So now we put the drug in the body, we've taken the drugs out of the pill, and now this solute form of the medication needs to diffuse into active sites. So this depends a lot on the physical characteristics of the drug, and we spoke about PCP, which has a pKa of, I think, around 9, I can't quite remember. And in the duodenum, the pH is around 8 something. And so that's the most basic point in the body. It's closest to the pKa of PCP, so that's where you get the most absorption, because most of the PCP will be in its most hydrophobic, its non-ionized state, which is what you're looking for if you want to pass biological membranes. So this is what absorption refers to, getting across the mucous membranes, lipid bilayers, whatever's going on, and getting into the circulation so that it can be delivered. And that's the D in I-LADMI. This refers to movement across lipid membranes. So let's say that we have a drug, it got into the duodenum, PCP for example, it's absorbed and its mode of action perhaps is in the brain. It has to move across the membranes, the blood-brain barrier membranes, to get into the brain, or it has to diffuse across the cell membranes of muscle cells to get into muscle, whatever the drug is, wherever it needs to go. That is delivery. It refers to delivery to the locus of action. And then you have metabolism. So metabolism, well, it refers to all the chemical alterations that might happen to the drug in the body. Now, some drugs need this to happen. Some drugs want to be metabolized so that they are converted into an active, effective form. Other drugs will be metabolized so that they can be excreted. So this turns them from active to inactive and gets them out of the body. Whatever the case, metabolism is done mainly in the liver, but it's also done in the brain, which we'll talk about later, mainly in glial cells, but also in neurons. And then finally, the E. So once we've metabolized it, we're getting ready to get rid of it somehow. And we can do that in all sorts of different ways. You can lose drug through micturition, defecation, sweat, shedding skin cells, hair cells, breathing it out as in alcohol, the breathalyzer test. And so that covers the ILAD-ME system, which is definitely something we want to have memorized for that first exam. The next thing we spoke about is modes of delivery, which I have on the screen here. And one of the things I'd like us to notice about the modes we have here is that they're all pretty common. You've probably heard of all these things if you haven't yourself been subjected to all of these things. So we'll start at the top, and you know that topical would be like a skin cream, lotion, acne gel, something like that. It just goes on the skin. We can go a layer deeper. We can put something just under the skin, so we're not in the muscles, we're not in the bloodstream, we're just under the skin. That would be subcutaneous. We can go deeper still, intramuscular, so right into the muscle mass. And then we can go deeper still, we can go beneath the muscles into the abdominal cavity in the intraparenteral delivery mechanism. And before we get to the mucosal absorption, what you can see here is that as we go deeper, we're getting faster. So topical is going to be way slower than intraparenteral. And it sort of is intuitive because you think if we're trying to get into the person, the deeper we go, the deeper we start the drug, the quicker it's going to get to its mode of action. And you'd be correct. It's intuitive. Mucosal absorption, though, can refer to putting it under the tongue, taking it in the nose, like cocaine, or an eye drop, something that interacts with the mucous membrane. And then IV. And IV gets right back to that deeper and deeper analogy we're using. We can go, instead of just putting it into the abdominal cavity, we could put it directly into the bloodstream somewhere so that it could circulate around, diffuse across vascular tissue and get into where it needs to go. So if you remember that deeper, 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 you have a pretty good idea of slow to fast for the test. And by the time we get here, we're sort of at medium speeds. Slow is up here. Here's around medium. Then we have some less common modes. And again, here would be medium, and here would be super, super fast. It's the quickest route of administration. So we just went from IV, and now we have inhalation. So we could inhale something, a drug, maybe even a toxin. You might think in chemical warfare, a lot of agents are inhaled, and it acts like that. While the combatants are in the cloud of mustard gas or nerve gas, they're experiencing it right then, right there within seconds. So you can think, inhalation is pretty quick. And even faster than that, we can put it into an artery, and that's faster because arterial pressure is going to be higher, right? So the blood there is going to be moving very quickly. It's going to get the drug where it needs to go. It's faster than intravenous. Then we have intraventricular, so in the CSF holding ventricle system of the brain and spinal cord, we could put drugs directly in there. The benefit of that is that the blood-brain barrier is especially permeable around ventricles. So if we're getting it in there, we might get it into the tissue we're trying to affect quite quickly. And if all that's too slow, we can go for the intrathecal route of administration, which is shoving the drug directly into the site of interest using a cannula, or cannulae, and this is a plural. But of course, this might cause damage. If I stick a tube into a mass of nerve cells, I might damage them with the tube. And then if I go ahead and inject some fluid, that increase in volume might also cause local damage. So really, when we get down here, this isn't something we want to do most of the time. But hopefully that makes sense, and we can sort of, when we're asked about this on the test, make intelligent claims about what's going to be faster and what's going to be slower and why. This is the color gray. So we're going to go into some terminology and then we'll do a graph. So we have LD50, which is LD, lethal dose. At LD50, that dose that we call the LD50 would kill about half of a population administered that dose. So if this was calculated in mice, if it's supposed to be 50 milligrams of a drug, and I give it to 100 mice, 50 of those mice should die. And that would be LD50. I mean, we have an accurate LD50. Then we have ED50, effective dose, or EC, effective concentration, which are similar. And this refers to the effective dose that would needed to reach 50% of maximal effect. So if let's say maximal effect is, and this is being completely hypothetical, paralyzing all 4 limbs. Maybe half of that effective maximal effect would be 2 limbs paralyzed. And so if I gave the ED50, that dose, to 100 mice, 50 of them would lose all of their, would have all of their limbs paralyzed, and the rest of them would have fewer. Of course, that's not really how drugs work, but you get the idea. It's not that, I'm doing a poor job of explaining this one, but it's not that the ED50 would accomplish only half of the effect. It's that half the time it would accomplish the whole effect. I hope that makes sense. The therapeutic index is LD50 over ED50, and it'll make more sense when we look at this graph. So what are we looking at here? First, we need to identify our axes. The dose is at the bottom here in milligrams, so as we move to the right, we're giving a larger dose of some agent. And as we go up, we have more and more individuals responding to that dose. So if we look at here, we have a drug that's supposed to cause hypnosis. Now if we give around 100 milligrams, half of people given 100 milligrams will be fully hypnotized, will be fully and properly hypnotized. That's the ED50. If we give about 100, or what would this be, around 250, 300, if we give about 300 milligrams, then 100% of people would be hypnotized. And nothing's really 100% in real life, but once we've given this much, we can be fairly sure the drug is going to have its effect. But there's a problem here. As we get into this region of the dose curve, of the effect curve, we're starting to get into the death curve over here. So as you can see, maybe this person is hypnotized, but there's also like a 5–10% chance that they're dead. Now you might imagine, wouldn't it be great if we can get these two curves really far apart, so that I can give 100, but maybe if I have a very resistant patient, I can safely give them 200 or 300 or 400 milligrams of this drug, and I wouldn't be on this curve because they're super far apart. Well, that would be great. And that's called the therapeutic index. It's how far apart are these curves. And the higher the therapeutic index, the better, because it means I can give more and more of this drug without risking killing the patient. And so we've identified the ED50. The LD50 would be right here where we're halfway up this death curve. And so what this is saying is that 400 milligrams, 50% of individuals given this drug will die. So we take the doses and we put them over each other. So the LD, the lethal dose, is 400, and the effective dose is 100, and so the therapeutic index is 4. Now, as we said, we want the therapeutic index to be higher, so what if you needed like 1,000 milligrams rather, to kill the patient, to kill 50% of people? Then the LDED would be 10. That would go up, and that would be good, and you can see it visually here. We would be moving the curves further apart, so we have a lot more leeway before we are risking the patient's life. Hopefully that made good sense. Here's some definitions. We know that neuroleptics are antipsychotic drugs. They also cause apathy, reduce initiative, blunted affect, but we use them anyway because they reduce confusion, agitation, and delusion. They also normalize psychomotor activity. This is a bit of a dry thing to do, but we do want to know all of the key points mentioned in lecture. Plasma protein binding is another big one. This refers to how drugs can, if I have a drug that's supposed to target my shirt, right, this shirt protein, who's to say it's not going to target the jacket protein or the undershirt protein or whatever else is in the area? They actually do that. So if we have a drug that's supposed to do one thing, it might be floating around in the bloodstream and just binding indiscriminately to proteins we didn't want it to bind to, and it's effectively wasted. So I want it to reach the shirt, but it's bound, it's stuck here to the jacket, and so this molecule of drug is completely useless. And the reason for this is given here. Once the binding occurs, the drugs aren't free to move out of the vascular compartment. And if the drugs are just floating around in the blood, well, that's not really doing anything. We want them to get into biological targets and exert their effect. And these coefficients can be as high as 90s and above in percentages. So that means that if I give you 1,000 milligrams of drug X, maybe 900 milligrams or higher are just going to be indiscriminately bound to random proteins and really not doing anything for you. Which sucks. If we had something that's a lower coefficient, a lower binding coefficient, then less drugs are needed to be taken because they won't be binding as much. They'll be going and doing their job. Obviously, pharmacy companies don't have much incentive to design such drugs, because if they have a high plasma protein binding coefficient, you have to bind more of it to get a given effect. So that's something we mentioned in class. We spoke about lipophilicity. Hopefully most of us know what that is. Lipophilicity describes the tendency of a molecule to enjoy the environment of lipid membranes. So can it float across a cell membrane very easily? If it's lipophilic, then yes. The downside is that if they like fatty environments, drugs will stay in the fatty environments. Why would they go somewhere else? And so what you might find is that there are drugs just trapped in tissues. They're trapped in adipose tissues, they're trapped in the brain, they're trapped wherever. And this can cause problems later, but that's sort of beyond the scope of what we discussed in class. As long as we understand what lipophilicity is, we should be fine. Now, we spoke about specificity and some approaches to enhancing it. Intrathecal is one method in which, say you want the drug to hit right here, you literally take a tube, stick it in right there, and inject the drug. Well, we spoke about that earlier, but it is used to enhance specificity. We want to know that. We can also cage a compound. Let's say that we want a drug that activates in the hippocampus. So what we do is we put this drug in. We design it so that it doesn't do anything until it achieves a certain stimulus, let's say frequency of light. We give it to the patient, we give it some time, the drug goes everywhere, it diffuses into all sorts of tissues, but it does also get into the hippocampus. But it's still inactive. So what we do is we take a light pipe, put it in the hippocampus, and shine a frequency of light on the caged compound, and it makes it active. So now the drug has been activated and it can exert its effect on the hippocampal neurons that we're trying to target. This is limited by the difficulty of designing such molecules and the potential damage caused by sticking a light pipe into the brain or into whatever locus of action you're trying to target. Finally, we have DREADs, designer receptors exclusively activated by designer drugs. And the name gives you all you need. The receptors are designed, and these receptors are only activated by drugs which have also been designed to achieve a certain effect. But there are problems with this. Well, we'll go into the problems in a second, but if you look at the last point here, specifically engineered receptors are infused into, so we don't know if this is a genetic way or some other way, they're infused into and expressed in specific populations of neurons. Then, because you know the receptor, you designed it, you design a drug to go target it, but there's some problems. These receptors are usually G protein coupled, and they're generally slow acting, so they're not designed to work. These drugs are not designed to work very quickly, so that's a limitation. And also, if you want to get the drug into a locus of action or the receptors or whatever you're trying to deliver, there can be problems from the infusion itself. We spoke about inserting a cannula, inserting a pipe, that can be problematic. So we see that theme again and again and again. So if we're asked about it on the exam, hopefully that that should be an easy point. And we spoke about this earlier, but pH and pKa interact to determine the site of absorption. If you don't know much about pH and pKa, I would go to Khan Academy and watch, spend about an hour going over those concepts, because they're very important, and I don't doubt they're going to be quite important in this course. So essentially, when we have a drug with a pKa that's in a pH environment close to that pKa, more of it will be non-ionized than if we were in a pH environment further away from the pKa. Which is good, because if it's not ionized, if it's not charged polar, it'll be more lipophilic, and it'll more readily cross lipid barriers. So I just mentioned that here. And then here's PCP, like I said, with a pKa around 9.4. And we did mention what it does. It's a non-dissociative anesthetic drug. Can cause hallucination, can cause violent behavior. Now, in the stomach, the pH is 1.4, and most of the PCP is ionic. So because it's ionic, because it's charged, it's not going to pass through lipid membranes very easily because it's not hydrophilic. But if we move to the duodenum, the pH is 8.4, and the drug, about 10% of it, will be in its non-ionized form and capable of absorption. And that's where the maximum absorption occurs, because that's where the pH in the biological system is closest to the pKa of the drug. Concordantly, drugs with low pKa's are absorbed in more low pH environments, like the stomach, and high pKa drugs are absorbed after a slightly longer delay, because they have to get down into the duodenum where the pH is higher. We know that pH of blood and CSF are about 7.4, so if we want a drug that is absorbed really easily, we want its pKa to be around 7.4. We then spoke about the blood-brain barrier, which is made of smooth muscles and epithelial tissue. We spoke about gap junctions, which are small gaps, small holes in peripheral blood vessels that allow small molecules to pass through, and tight junctions, which are sort of in contrast to gap junctions. They're very tight, they're small gaps, and only tiny molecules can pass through. So as you might imagine, the blood-brain barrier is a bit harder to get through than normal tissue with gap junctions in it. And as I mentioned earlier, the ventricles, as in the intracerebroventricular or intraventricular administration, are more susceptible to small molecules passing through than other areas. We also spoke about the 3 layers of the blood-brain barrier, so the endothelial cells, the basement membrane, and astrocytic processes. We always knew, hopefully, from cellular that astrocytes are involved in the blood-brain barrier, but there's a bit more to it, which we see here. They're transporters that carry things across the blood-brain barrier, but we want to know that water, oxygen, carbon dioxide can get across pretty easily. The blood-brain barrier does provide a pretty substantial obstacle to people coming into, not people, but molecules coming into the brain. So that's something we might want to know. Bulk metabolism, another definition, takes place in the liver, but does not occur to heavy metals. Enzymes are involved in that. We also have metabolism in the nervous system, neurons, more often glial cells. And we know that metabolism plus excretion, which is why we're talking about metabolism here, wherever it occurs, is equal to drug clearance. So we want to have that definition of drug clearance, how much of the drug is cleared from the system. Half-life, let's say that we have a drug that lasts in the system for 16 hours. The half-life is 8 hours. It's half the total amount of time the drug stays in the system before it clears. Then we have the half-time, which refers to the amount of time required for a drug to fall from any given concentration to half that concentration in a biological setting. And half-time is important because in order to get steady-state concentrations of a drug, you want to achieve about 4 half-times. So we take the drug every half-time, and after doing that 4 times, we have the maximal concentration that we're going to get in the bloodstream. And that's how you take drugs. And we know that clearance is max between 1 year and puberty, then rates decline, stabilize around the mid-40s, and then pretty much peter off from there. And that's pretty much what we spoke about in the first week. I hope that was beneficial, and I hope to have time to do this for further chapters. Let me know if there are any questions.